long-term conditions and the management of them is key to good clinical care, but it also requires understanding the context in which people live and where they are, and engaging with them as to their motivations and enabling them to take responsibility and enabling them to care for themselves. You know, so for example, I think of someone who's got diabetes and has a BMI of 40 and is a smoker. And, you know, if you asked a diabetologist what is the most important thing about that person, they would say get them to stop smoking. But having a conversation with her, losing weight is much more important for her because she's actually got chronic pain from an operation that went wrong many, many years ago, and she perceives that that would not only improve her mental health if she lost weight, but it would also improve her pain. And so my biomedical approach to thinking the worst thing that's happening to this woman at the moment is that she's smoking, it needs to be put aside because there's very little point in me going on about that constantly. If where she is at a place where she's going to try and lose weight, and she did that, and she lost several stone over the course of a year. There's lots of talk about vulnerable groups, and people have mentioned that already this morning, and it is important to consider how we provide services, and lots of work has been done on that within PCTs, lots of specialist appropriate services developed with community or patient involvement, and I think it's very important that that learning and these services are not lost. Often these services have been set up with champions who really felt that it was important to get excellent care for the homeless or for prisoners or for gypsies and travellers, as has been mentioned, and so on. And I think it's very important that we know how best to keep these services going. But always we must be thinking, and I suppose more so in times of austerity, is where can a difference be made? And of course, I mean, it's my view that the ability to make a difference for the individual patient in front of you is what the privilege of general practice is about. And a few branches of medicine have that degree of privilege, and so it is about that unconditional and open-ended commitment. And I think it is that's largely where GPs see themselves in individual consultations, seeing patients in their own context, but focused on that individual. Barbara Starfield from Johns Hopkins in the US sums up primary medical care as this first contact access for each new need, long-term person rather than disease care, comprehensive care for most health needs, and coordinated care when it must be sought elsewhere. And so there is, within that model, the potential to address a number of contributing factors that cause ill health. But general practice and primary care, particularly now, involves more than individual contact. And I think the public health role of GPs is more contentious. And if you went to speak to individual GPs, I'm not talking about people who work in PCTs and so on, but you know, you speak to individual GPs who do that as their full-time job, most of them wouldn't see themselves as deliverer of public health services at all. But I think it can be argued that primary care is the place where public health has been worked out on a day-by-day basis. Because public health, as we know today, is about interacting with people. You know, so quite different from the origins where, you know, classically public health was concerned about dirty water and appalling housing conditions. In fact, what we're engaging with, what we need to do is engage with people about behavioural change. And you can have an argument whether general practice is a place that happens or whether there's somewhere else. But the issue about general practice is people largely, 80% of the population will attend practice. And actually, you can argue there's a long tradition of general practice delivering public health on the ground, immunisation programmes, cervical screening, etc. And so although we may need to have to change our thinking a little bit, there actually is a good record of that. And even current big public health issues that we mentioned, smoking, obesity, alcohol excess, can be partly addressed by public health campaigns, but all of these, I think, need individual engagement. One of the increasing ways GP teams can contribute to public health is having aware of their data and of the use of data that's available to them. And I think this is something that individual teams and commissioning groups are going to have to be much more savvy at as things change. I also think the great resource in public health teams within PCTs needs to be very carefully looked at so that that resource and these data are used in the best possible way. Commissioning is a hot topic, and the college, our college and the Health and Equality Standing Group are really committed over the next year or two to try to have a campaign really to engage with the new commissioning consortia as they emerge, engage with them about how they might commission services to reduce inequalities. And this whole big topic of inequalities is not lost in the difficulty of all the new things that need to be learned. Somebody said earlier we had to move away from targeted interventions. I'm not sure that's true in terms of healthcare and of primary healthcare. I think we do need to think about what populations will benefit most from interventions. And we need to remember that if you don't target, and this has been the lesson of some of these campaigns, if you don't target, you increase inequalities. And smoking cessation was a great example of that in the early years, where smoking cessation was offered across areas and was taken up disproportionately by affluent people. So absolutely fine for them to have smoking cessation services, but unless you target the people most in need, that is the outcome. We also need to be very careful we don't set up systems to increase inequalities. And there's an anomaly and I'll come on to the GP contract, but there was an anomaly that we still refer to the new GP contract, but the 2004 contract about cervical screening, which had the potential to increase inequalities. There weren't actual targets for cervical screening, to my knowledge, before, but if you were a training practice, certainly in our area, you needed to get 80% of the eligible population for cervical screening screened, or you would lose your training practice status. And in a very deprived area, that was a real difficult target to meet. And every year we had to look very closely at it, and we scraped it, and that was with making sure that we didn't have any so-called ghost patients and so on our list. But it was very, very challenging, and that's a target that's easily met in affluent areas. However, post-new contract, the pressure came off that because the cervical screening's in it. But if you send somebody three letters and they don't turn up, you can exclude them. So you can get 100% really very easily, but actually you've screened less people. And so, good clinical governance required you to look at the raw data and to look at how many people were actually being screened, not at what your percentages look like. And we developed, in our practice, we developed ways of ensuring that we didn't stick to just the contract figures, but that we looked at the people who were being screened. So we have to be very careful that we don't, that things to set up more inequalities aren't put into contracts. Prevention of cardiovascular disease in people with hypertension has been very successful. Smoking cessation, obviously, we've mentioned. Detecting diabetes and impaired glucose tolerance, these are also important. That might be particularly important in some areas with big Asian populations where these are more prevalent. And all this stuff has now been badged as anticipatory care. This is the Scotland answer to it. Keep Well programme, targeted intervention to detect undiagnosed hypertension, diabetes, etc. in socioeconomically deprived communities. Many places have done something very similar. This was an example of a secondary prevention programme in Sheffield in 51 practices, and they reduced the cardiovascular mortality in the under 17.5s in the most deprived fifth of Sheffield. There was a 23% decline. in the most deprived fifth, whereas the decline in the whole of Sheffield was 16%. So these which involve huge amounts of effort and engagement, these have shown to be successful. What have I done? Haha. To move on, partnership with other agencies is something I think that in many places, and that's why I'm so impressed by being here today, people have found difficult. And of course, there's partnership on the big levels, like this conference is about, and about the people who run organisations being committed to partnership. But then there's the actual working of the partnership on the ground on behalf of individuals. And these two things, one may work quite well, but the other may not necessarily follow. So I think that is important. There have been places which has worked incredibly well, like the Bromley by Bow Centre in London, which involves the voluntary sector, the local authority. Much more talk about social prescribing, and some of these interventions I've described do use social prescribing as part of what they offer. That's the Bromley by Bow Centre website. It's hard to think that that's actually a health centre, but if you click, eventually you get to health and well-being. And that's an example where a number of very committed individuals, both from the GP practice actually, and the third sector, have been very successful there.